Welcome to the Deep Dive. Today we're tackling a really significant topic in healthcare, how cancer actually develops. I mean, the numbers alone are pretty sobering. We're talking about, what, 1.8 million people in the U.S. and Canada getting diagnosed each year?
Yeah, it's huge. And while we know the risk isn't the same for everyone, genetics, immune factors, environment all play a part, the core thing remains. Understanding the biology is absolutely fundamental for prevention and catching it early.
Exactly. So today we want to go beyond just the big numbers. We're doing a deep dive right down to the microscopic level into the concepts of cancer development. We're aiming to really unpack those specific biological changes that make a normal cell just lose control and turn malignant.
That's the plan. And the main idea, the priority concept weaving through all of this is cellular regulation.
Right. And the related concept, which we'll definitely touch on later, is immunity.
Okay, so let's start with the basics. What is normal cellular regulation? Essentially, it's the body's genetic and physiologic system for keeping things balanced, maintaining homeostasis. It controls how cells grow, when they divide, how they specialize, differentiate, and what jobs they do.
And most cells aren't dividing all the time, right?
Not at all. A normal, mature cell spends most of its life in what's called the G0 state. That's its working phase, its resting phase, really. It only jumps out of G0 to divide if the body specifically needs it to, for growth during development or to replace cells that are lost or damaged.
So there must be some kind of control mechanism ensuring division only happens when needed, like signals.
Precisely. Think of it as a delicate balance managed by genes producing opposing proteins. You've got proto-oncogenes. These are like the gas pedal. They make proteins, specifically cyclins, that push the cell towards division.
Okay, the go signal.
Right. And then you have the suppressor genes. These are the brakes. They make proteins that limit division and basically keep those cyclins in check. Normal cells only divide when the brakes are eased off and the gas is gently pressed. It keeps growth orderly and, necessary.
So that covers the growth part.
Yeah.
But isn't another key feature of normal cells that they also know when to quit?
Absolutely crucial point. Apoptosis. Programmed cell death. Normal cells aren't immortal. They have a limited lifespan. See, every time they divide, the little caps on the ends of their chromosomes, the telomeric DNA, get shorter.
Like a countdown timer.
Kind of, yeah. Once that DNA cap is basically gone, the cell gets the signal to self-destruct. It's a built-in safety mechanism to get rid of old or potentially faulty cells.
Okay, that's the normal picture. Now let's use that to understand abnormal growth.
Okay.
First up, benign tumors. These can be confusing. How are they different from actual cancer?
Good question. Benign tumors are a result of neoplasia that just means new growth the body doesn't need. Think of things like moles, skin tags, or maybe uterine fibroids. The key difference is they're still mostly like normal cells. They keep their specific morphology, meaning they look like the tissue they came from. They're well differentiated.
So they still look like, say, fibroid tissue or mole cells.
Exactly. And they usually have tight adherence. They make enough of those sticky proteins, the cell adhesion molecules or CAMs, to hold together. They're also non-migratory. They grow by expanding outwards, pushing tissues aside, but they don't invade them.
And chromosomally.
Usually aploidy, meaning they have the normal number of chromosomes, just like regular cells.
Okay, so benign means abnormal growth, but it's still playing by most of the rules, which implies malignant, or cancer cells are just rule breakers.
Complete biological rebels. Malignant cells have thrown cellular regulation out the window. They exhibit anaplasia.
Anaplasia, meaning?
Meaning they lose that specific appearance of their parent cell. They often become smaller, more rounded, sort of generic looking. You might not even be able to tell where they originated. Their nucleus also tends to get really large compared to the rest of the cell, a larger nuclear to cytoplasmic ratio.
And if they lose their specific look, I imagine they lose their specific job too.
They do. They lose their specific functions. They don't contribute anything useful to the body. And remember that tight adherence in benign cells. Malignant cells lose it. They don't make enough CAMs, leading to loose adherence. They break off very easily.
Which sounds like a recipe for spreading.
Precisely. That loose adherence facilitates migration and ultimately metastasis. They also lose contact inhibition. Normal cells stop dividing when they bump into neighbors.
They know when the space is full.
Malignant cells don't care. They just keep piling up, dividing even when they're completely surrounded. And maybe the most critical feature, they become immortal.
How does that work? They bypass that apoptosis, the self-destruct sequence?
They do. Often they manage to switch on an enzyme called telomerase. This enzyme rebuilds those telomere caps on the chromosomes, so the countdown clock never runs out. The cell ignores apoptosis signals and can just keep dividing indefinitely.
Wow. And chromosomally, they're different too.
Yes, unlike the usually euploid benign cells, malignant cells are very often aneuploidy. They have an abnormal number or structure of chromosomes. Things are broken, rearranged. It's chaotic. And generally, the more aneuploid they are, the more malignant.
Okay, so we see the stark difference between normal, benign, and malignant. Let's transition now. How does a perfectly normal cell make that switch? That process carcinogenesis, you said it happens in stages.
It does. It's usually a multi-step process, often taking years. It starts with step 1, initiation.
Initiation. Sounds like the starting gun.
It is, and it's an irreversible event. Initiation is damage to the cell's DNA caused by exposure to a carcinogen, could be a chemical, radiation, maybe a virus. This damage does one of two critical things. It either flicks proto-oncogenes, the gas pedal, into an always-on state, turning them into oncogenes, OR.
Or it damages the brakes.
Exactly. Or it damages the suppressor genes, taking the brakes offline. Either way, you lose that crucial balance of cellular regulation, leading to excessive cell division.
So the genetic damage is done, the switch is flipped, but it's not necessarily a tumor yet.
Not usually, no. The cell is now susceptible, but it might just sit there, or even be eliminated by the immune system. It needs step 2, promotion.
Promotion. Like boosting its growth.
Precisely. Promotion is when the growth of that initiated cell gets enhanced by substances called promoters. Interestingly, these can often be normal body hormones like insulin or estrogen. Environmental factors can also act as promoters. The key here is the latency period, the time lag between initiation and when a tumor actually becomes detectable.
Which could be long, right? Months or years.
It can be very long. Promoters effectively shorten that latency period, speeding up the development of the tumor.
Okay, initiated, then promoted. What's next?
Step 3, progression. This is where the tumor really starts to become a serious problem. It develops its own infrastructure. A key part of progression is angiogenesis, creating its own blood supply. Tumor cells start pumping out vascular endothelial growth factor, or VEGF.
VEGF, that signals blood vessels.
Yeah, it basically tells nearby blood vessels to grow new capillaries right into the tumor, feeding it nutrients and oxygen. And during progression, the tumor cells keep changing, keep mutating. This leads to different groups of cells within the same tumor.
You mentioned driver and passenger mutations earlier.
Right. Some mutations are driver mutations. They give the cell a survival advantage, help it grow faster, resist therapy, things like that. The tumor selects for these. But it also picks up lots of other mutations along the way, passenger mutations, that don't really do much for its growth.
But they're still useful clinically.
Incredibly useful. Because they're unique to that cancer, they can sometimes be used as targets, like for immunotherapy or to track the cancer's origin. The original tumor site, by the way, is called the primary tumor.
Okay, initiation, promotion, progression, leading to the most feared stage. Step 4, metastasis.
Metastasis. The spread. This is when cells from the primary tumor break off, travel, and set up shop somewhere else, forming secondary tumors or metastatic tumors.
And this is where that naming convention is critical for students to grasp.
Absolutely vital. If, say, breast cancer spreads to the lung, it is not lung cancer. It is breast cancer that has metastasized to the lung. The secondary tumor is still made of breast cancer cells, always identified by the primary origin.
How do they actually travel? You mentioned loose adherence earlier.
That's key. They can invade locally, just spreading into adjacent tissues, often by releasing enzymes that digest barriers. But the most common way they spread long distance is blood-borne metastasis. Remember those loose cells? They can secrete enzymes that basically poke holes in blood vessel walls.
So they just slip into the bloodstream.
They do. They circulate around the body, and then they can stick somewhere else, exit the bloodstream, and start a new tumor. Lymphatic spread is another route, often faster in areas with lots of lymph channels.
Okay, understanding that whole process is huge. Now, once cancer is found, how do doctors classify it? You mentioned grading, ploidy, and staging. This seems really important for prognosis and treatment.
It's absolutely critical for planning treatment and predicting the outcome. Let's start with grading. Grading looks at the cells themselves. How different do they look from the normal tissue they came from?
So how abnormal are they?
Pretty much. It's about differentiation. G1 is low grade. These cells are well differentiated. They still look a lot like the normal parent cells. They tend to be slow growing. G4, on the other hand, is high grade. These cells are poorly differentiated or undifferentiated. They've lost almost all resemblance to the normal tissue. They're usually very aggressive, grow rapidly, and sometimes you can't even tell the tissue of origin.
And does grading relate to the chromosome situation, the ploidy?
It often does. Ploidy describes the number and structure of the chromosomes within the cancer cells. Remember, normal is euploidy 46 chromosomes. Nice and neat. Malignant cells, especially high-grade ones, are often aneuploidy. They have abnormal numbers, bits missing, bits added, rearrangements.
Like the Philadelphia chromosome.
That's a classic example of aneuploidy in chronic myelogenous leukemia. The more chaotic the chromosomes generally, the more aggressive the cancer tends to be.
Okay, so grading is cellular appearance, ploidy is chromosomes. What about staging?
Staging is about the anatomic extent of the cancer. Where is it exactly and how far has it spread? Has it invaded locally? Are lymph nodes involved? Has it metastasized to distant sites? There are different ways to stage clinical, surgical, pathologic, but pathologic, looking at the actual tissue, is the most definitive.
And the main system used is TNM.
For most solid tumors, yes, the TNM system. You need to know this. T describes the size and and/or extent of the primary tumor. N describes the involvement of nearby lymph nodes. And M indicates the presence or absence of distant metastasis.
So like a T1N0M0 might be a small tumor, no nodes, no metastasis.
Exactly. Whereas a T4N2M1 would be a large invasive tumor with significant node involvement and distant spread. It gives a much clearer picture of prognosis.
Very important.
Crucial. But remember, TNM isn't used for all cancers, notably not for leukemias or lymphomas, which are inherently widespread.
We also briefly measure growth speed.
Yeah, things like doubling time, how long it takes the tumor mass to double, and the mitotic index. That's the percentage of cells actively dividing. A high index, like say 85%, means very rapid growth. Less than 10% is slow.
Okay, that gives us a solid framework for understanding the biology and classification. Now let's zoom back out. What actually causes this whole process to start? What are the big risk factors?
Well, it usually boils down to an interaction between three things: your exposure to carcinogens, your individual genetic makeup, and the strength of your immune system.
But you mentioned a really striking statistic earlier.
The 80% number, yeah. It's estimated that about 80% of cancers in North America are related to external factors, environmental exposures, lifestyle choices.
That's huge. It means most cancers are potentially preventable if we address those external factors.
That's the implication, and it's profound. The biggest category here is chemical carcinogenesis, and the single worst offender,
Tobacco.
without a doubt. Tobacco smoke contains numerous carcinogens. It's the single most preventable cause of cancer, responsible for maybe 30% of all cancer deaths. And don't forget co-carcinogens. Alcohol, for example, might not be strongly carcinogenic on its own, but combined with tobacco, they dramatically increase the risk together.
Does it matter where the exposure happens?
Well, tissues with cells that divide more frequently are inherently at higher risk because there are more chances for DNA errors during replication. Think bone marrow, the lining of your GI tract, skin, lung tissue.
Okay, besides chemicals.
Physical carcinogenesis. This includes things that physically damage DNA. Radiation is a big one, both ionizing radiation like from radon gas or medical x-rays, and ultraviolet radiation from sunlight or canning beds. Also, chronic irritation or inflammation. Think of burn scars that never quite heal right, or long-term tissue injury. That constant cell turnover raises the risk.
And then there are the viruses.
Right, viral carcinogenesis. Certain viruses called oncoviruses can directly cause cancer. They do this by inserting their own genetic material into the host cell's DNA, messing it up.
Key examples students should know.
Definitely HPV, human papillomavirus, links strongly to cervical, throat, and anogenital cancers. Hepatitis B and C viruses, major risk factors for liver carcinoma, and Epstein-Barr virus, associated with certain lymphomas.
What about diet? That comes up a lot.
Dietary factors are suspected, though the links can be complex. High risks seem associated with diets low in fiber and high in red meat and animal fat. Also, things like nitrites, used as preservatives in lunch meats or bacon. And, of course, excessive alcohol intake is a risk factor on its own, too.
Okay, those are the external factors making up that 80%.
Yeah.
What about personal factors? You mentioned age.
Age is actually the single most important risk factor for cancer overall, primarily for two reasons. First, simply accumulated exposure over time to all those environmental factors we just discussed. Second, and critically, Immunity generally declines with age, particularly after age 60. That natural immune surveillance, where your NK cells and T cells patrol and destroy abnormal cells,
It gets less effective.
it does, which gives initiated cells a better chance to survive and progress. This is also why people who are immunosuppressed, like transplant recipients or those with advanced HIV, have a higher cancer risk.
And finally, the inherited genetic risk.
Genetic predisposition. This only accounts for a small fraction of all cancers, maybe 5–10%. But for families affected, the risk can be extremely high. This usually involves inheriting a mutated copy of a really important gene, often a suppressor gene like BRCA1 or BRCA2, associated with breast and ovarian cancer.
Are there signs that suggest a family might have one of these inherited risks?
Yes, there are red flags nurses should be aware of. Things like cancer appearing in multiple generations, multiple first-degree relatives having similar cancers, family members developing rare types of cancer, or people getting cancer decades younger than is typical for that type.
Okay, understanding all these risks leads directly to prevention. This is where nursing plays such a huge role. We talk about primary and secondary prevention.
Exactly. Primary prevention is all about stopping cancer before it even starts. The most effective strategy. Avoidance of known carcinogens.
Like quitting smoking, using sunscreen.
Absolutely. Educating patients on skin protection, smoking cessation, using protective gear if they work with chemicals, that's paramount. Then there's modification of associated factors, limiting alcohol, generally recommended no more than 1 drink per day for women, 2 for men, and dietary changes.
You mentioned diet earlier. What are the key recommendations?
Focus on a high-fiber, lower-fat diet. Specifically, try to avoid excessive animal fat and red meat. Minimize intake of nitrates, so less processed meats like bacon and lunch meats, and increase intake of bran, cruciferous vegetables, broccoli, cauliflower, cabbage, and foods rich in vitamins A and C.
Primary prevention can also be more active, right? Like removing risky tissue.
Yes. Removal of at-risk tissues is a primary prevention strategy. Removing suspicious moles or colon polyps before they can become cancerous, for instance. There's also chemoprevention, which is using drugs or specific nutrients to try and disrupt cancer development. Examples include things like aspirin or Celebrex, potentially reducing colon cancer risk, tamoxifen or vitamin D for breast cancer risk, or lycopene for prostate cancer.
And vaccination.
Huge one. Vaccination against oncogenic viruses is primary prevention. The HPV vaccines, Gardasil and Cervarix, are prime examples, preventing infections that cause the vast majority of cervical cancer.
Okay, that's preventing it from starting. What about secondary prevention?
Secondary prevention is about early detection. Finding cancer when it's small, hasn't spread, and treatment is more likely to be successful. This relies heavily on screening.
And patient education about warning signs.
Yeah.
This is where caution comes in.
Yes, the CAUTION acronym is a critical teaching tool, especially for older adults who are at higher risk. Every student should know this. C is for changes in bowel or bladder habits.
Okay.
A is for a sore that does not heal.
Right.
U is for unusual bleeding or discharge.
Mm-hmm.
T is for thickening or lump in the breast or elsewhere.
Got it.
I is for indigestion or difficulty swallowing that's persistent.
Okay.
O is for obvious change in a wart or mole.
Mm-hmm.
And N is for nagging cough or hoarseness.
That's a really practical tool for patients.
It is, and it needs to be coupled with regular screening tests based on age and risk factors. Things like annual mammograms for women starting usually around 45, annual fecal occult blood tests, colonoscopies, digital rectal exams for men over 50. The guidelines are specific.
And genetic screening fits here too.
It does. Under secondary prevention, if someone has that strong family history we talked about, genetic screening for mutations like BRCA1 or APC might be recommended. But it's complex. Genetic counseling is essential beforehand. A positive result means high risk, not a certainty of cancer. And a negative result only rules out that specific mutation.
Right. Lots of nuances there. Okay, so we've covered a lot of ground. We did a deep dive into that loss of cellular regulation, traced the steps of carcinogenesis from initiation all the way to metastasis, and looked at how we classify cancers using grading, ploidy, and TNM staging. I think the big takeaway for you, listening as a nursing student, is really internalizing those two core failures of cancer cells. They lose regulation, leading to that uncontrolled growth, and they lose apoptosis, achieving that dangerous immortality. Understanding that helps predict how they'll behave and why prevention is so key.
It really does, and it leads to a bigger question, doesn't it? If tobacco is the biggest single preventable cause, and if 80% of cancers are linked to these external environmental factors, What more could we be doing from a public health or even a policy perspective beyond individual patient teaching, like caution, to really tackle the root causes and prevent the vast majority of these cancers from ever happening in the first place? Something to think about.
Definitely something to think about. Thank you for joining us for this deep dive into the concepts of cancer development. From the Last Minute Lecture team, good luck with your studies.